Hello, and thank you for joining the Systems for Action Research in Progress webinar. My name is Chris Lytle. I'm Deputy Director at Systems for Action. And for folks new to what we do here, we're a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies examining multi-sector collaboration across medical, social, and public health systems with a goal of improving population health and advancing health equity. So today we're joined by an S4A research team based at the National Committee for Quality Assurance to discuss their study, which explored the impact of linking medical homes to social service systems for Medicaid populations. So we'll have a presentation from following Carrie Christensen, Dr. Sarah Hudson-Scholl, and Dr. Phil Sasnick, along with Jenny Susi, followed by commentary from Carolyn Fitchenberg, Dr. Carolyn Fitchenberg from Social Interventions Research and Evaluation Network. And we'll keep some time at the end for Q&A. So as you have questions after the commentary or throughout the presentation, feel free to add it to the Q&A box at the bottom of your screen. So with that, I'm going to introduce our presenters for today. Dr. Scholl is Vice President of Research and Analysis at the National Committee for Quality Assurance. Dr. Scholl is an expert in health services and quality measurement in multiple settings and has a demonstrated record of moving innovative measurement concepts into implementation, particularly through NCQA's healthcare effectiveness data and information set. Carrie Christensen is an innovation-driven strategist, program manager, and entrepreneurial leader with 15 years plus of success in the intersection of health information tech, data, and healthcare with a focus on social risk and health equity. She's the Director of Strategy, by the way. Dr. Sasnick is the Phyllis Torta Healthcare Quality Fellow at NCQA. He's a 2019 graduate of the Health Policy Program, PhD at the Harvard Business School and Graduate School of Arts and Sciences. His work aims to identify the drivers of performance for healthcare organizations and providers and the mechanisms by which this performance can change over time. So with that, I'm going to, left off our commentator. Carolyn Fitchenberg is the Managing Director of the Social Interventions Research and Evaluation Network and research scientist in the Department of Family and Community Medicine at the University of California. So with that, I'll hand it over to the NCQA team. And of course, add any questions you have throughout in the Q&A box in the bottom.
Great. Chris, thanks so much. I'm Sarah Scholl, and I'm delighted to have this opportunity for our team to present the work that we've done in this project. We're grateful to the Robert Wood Johnson Foundation for supporting this work. Understanding how healthcare organizations interact with community-based organizations is just a critical issue for our country right now as we try to address health equity and figure out how to identify and deal with and support people as they encounter adverse effects of social determinants. And what we're going to be sharing today are some lessons that we've learned and observed in this work as we set out to understand, how do you link and how hard that is. So we hope that what we've learned will be instructive, useful, and help others to overcome barriers that we met. In addition, we have some really important quantitative findings about social needs and how they vary over time, which we think is a really important addition to our knowledge about this. So with that, I'd love to turn it over to our great team to talk through the work. Thanks so much.
Thanks, Sarah. Okay, so as you can see, hopefully on the slides, we're going to do a brief project overview, talk a little bit about what we intended to do, what we ended up doing, and then we'll talk some about our qualitative findings, and I'll turn it over to Phil to talk about some quantitative work we've done. All right, we practiced this. Come on, slide. Oh, there. All right, great. So we started off with two different goals. Looking at connecting medical homes and community-based organizations with a technology platform. And we were interested in how that enabled communication between the medical homes and CBOs would actually impact the quality of care and the utilization of emergency and hospital services, as well as being interested in how that connection actually would affect the identification of social risk, the referrals to CBOs, and how the communication loop was closed on those referrals, as well as receipt of services. That is not actually what we ended up accomplishing during this project, but we were looking at a little bit of a natural experiment with a couple of groups in the Chicago region, County Care and Medical Home Network, who were implementing this Community Care Connect program, which is building on an existing system that they had, but connecting that medical ecosystem to the community-based organizations in their area. And you can see that they're being able to provide information about the patient across the system, so both on the medical and community-based organization side. It enables bidirectional communication, referral tracking, and really lets people take action together collaboratively on their shared patient populations. Carrington, I'm not sure. Thank you. Okay, so our project plan, like I said, was actually looking at the plans to look at the intervention and the impact of that intervention on the patient population as well as the providers. But it turned out that despite Medical Home Network's expertise in this area, rolling out similar platforms in the medical side, we ran into a lot of barriers and challenges to be able to get the implementation done as quickly as was seen in the medical space. So that delay in project implementation delayed the evaluation, and we revised the project plan to really capitalize on what we were learning throughout the project. All right, so what we decided to do instead was some qualitative work and then some quantitative work. And on the qualitative side, we did interviews with all the stakeholders to understand the barriers to implementation and those lessons learned from the community-based organization, medical home, and the project sponsor's perspective. And that's what I'm going to talk about. And then Phil is going to talk a little bit about how we used the existing very rich data set of 5 years of information around people's social risk to understand how that risk changes over time for a population and what the different patterns were that we were able to see. Okay. So let's talk about the qualitative work. The goal was to understand those barriers to implementation and the lessons learned from the staff at the community-based organizations, the medical home, the project sponsor. The setting, like I said, is medical homes and community-based organizations that are in Cook County, Illinois. We worked with County Care, which is a Medicaid managed care plan, and Medical Home Network, which is an ACO, and they also provide technology services in this setting. We did 23 interviews that were half an hour long, in person and by phone across 9 different organizations, looking at leadership level staff, project owners, and end users. And what we found was that the information we gleaned from these divided up into some key themes, which let us develop a list of 10 different types of issues, which we'll talk about. We then captured lessons learned and recommendations for other folks going through this implementation journey based on those themes. Okay, so let's talk a little bit about each of the issue types that were identified. The first three really deal with privacy type issues. So we've got concerns around HIPAA, concerns around Part 2, which is the sharing of substance use information, and patient consent. And these came up a lot, both from people who actually understood what they mean and from people who kind of had an understanding of what they meant and knew that it was important for them to think about sharing their patients' information and being in compliance with these, but didn't necessarily understand it. So those will come up a lot throughout the results of the project. Trust and relationships was another one. Whenever you're implementing new technology, obviously it's important to understand what the existing relationships and workflows are. And we found that people were not able to overcome those patient privacy concerns when they were talking with people that they didn't have existing relationships with necessarily. The technology made that a little more difficult for them. So that's a whole area to be looked at. And then finally, consistent engagement, again, is not going to be a surprise to anybody, but as people turn over or are able to engage and then may not have time later to engage in a project, that really slowed projects down to have a shifting group of people and you had to make decisions over and over again. Let's see. The next couple of concerns, data availability. Whether or not information was available and when for what types of patients was a little confusing for people and kind of eroded some of their understanding about what was going to be there and when. Having a consistent vision and goal was important to make sure everybody was working towards the same thing. System integration is just that technology, making sure that you've got your technology talking to each other in the best way. Workflow alignment talked about whether or not the new things we were asking people to do actually worked into what they were doing already or whether it was an additional ask. And then education is the kind of catch-all at the end, talking about if you haven't already covered it in one of the other issues, educating people on what's supposed to be happening can help. So those were kind of the 10. And then what we did with those is we thought about who those lessons learned and recommendations are most important for. So here you can see we looked at two different types of staff, leadership on the left and project management on the right. And then we looked at two types of organizations, the funder, which in this case was the health plan, and the implementer, who's actually implementing the technology. And so we found that for one of our lessons learned, lesson learned number 13, the lesson itself was that when you're asking people to do new kinds of work, right, adding in a new workflow, there's got to be a benefit to them. So this technology was provided for free at no cost to the community-based organizations, but we were asking them to use their own resources to do a particular kind of work, right? So it is important to understand that just giving someone access to something for free may not be enough to drive the actual implementation. So what kinds of things did Medical Home Network do to help with overcoming that barrier? And that's where we've got our 4 recommendations here. So let's start with recommendation 13.1. You can see it in the bottom left-hand corner. This one is relevant for leadership at the implementation organization. So this is saying it's important to provide access to the platform at no cost to the community-based organizations. Then we can move to a lesson for the leadership at the funder or the health plan. So this is saying we want to make sure that we're providing funding or other benefits to all the organizations that are being asked to do something, right? So the CBOs need to have some kind of incentive to use this, and they're probably not going to actually make any money or save any money based on using the platform. So what else is the incentive that's going to get them to drive that adoption? In the project management implementer box, we see there's 2 recommendations. One of them is to ensure a clear understanding of the CBO's goals and needs to make sure they're being met. And the other is to work with them to understand those reasons that are going to help them be able to gain benefit from the platform. Okay, so each of the lessons learned and the recommendations in the paper that we've completed has a tagged staff type or multiple staff types, an organization type or multiple, and the 10 issue types like we talked about before. And our end product is going to be this white paper. We're hoping to get it published on the internet in the next couple of days. And when that happens, we'll make sure to notify you all with those lessons learned and the recommendations. And one of the exciting ways that we're going to disseminate that work actually can involve all of you. So I want to tell you a little bit about it. We have a new digital measurement community at NCQA that launched in the fall. And this is going to allow us to actually have a conversation with you all. And we would love to hear your thoughts about the lessons learned and recommendations that we made, things that you've seen, things that you've been successful with, or challenges you've experienced in similar implementations, to really continue the conversation and help share knowledge across all the folks in the space that are trying to do this work. So with that, I am going to turn it over to Phil to talk about our quantitative work.
Thanks, Carrie. We could just move to the next slide, please. So Carrie's presentation focused on sort of the barriers to implementation in this context. What were the challenges to integrating between the CBOs and the clinical providers? And my work will be focusing on a slightly different part of the system, and that's specifically what was the content of the intended communications between the clinicians and the CBOs. And in this context, we're thinking primarily about data on unmet social needs of this patient population, this Medicaid managed care population. So the key problem here is that understanding the evolution of these social needs is important both to managing population health, documenting challenges around equity and access, but also to evaluating the usefulness of tools like the health risk assessment data that were being collected and intended to be shared across them. So to push on that a little bit further, the idea would be that if social needs, unmet social needs in particular, are relatively stable, you might want to maximize the number of people who were screened for a health risk assessment once, whereas if you think they're highly variable over time, you'd want to emphasize repeated assessments and think carefully about the design of an assessment to capture that variation over time. However, in populations like Medicaid, frequent patient churn due to changing eligibility status and frequent churn in provider empanelment, so changing in the clinicians that a patient is seeing, can complicate following a stable population over time and documenting these trends. The data that came out of this collaboration with the Medical Home Network actually created a sample with sort of a large patient population and also a long time series that lets us depart from those normal limitations and document a stable population of patients over time and get a sense of these trends. And that brings us to our specific research question, which was how do social needs change over time in a Medicaid population? Asking whether these patterns differ based on observable characteristics of those patient populations, like initial medical risk, and in particular, which social needs were most likely to change over time. And I'll get into all of those in a bit more detail in the coming slides. Next slide, please. So just to say a bit about the setting, Carrie, I think, touched on this some already. The Medical Home Network is an accountable care organization providing care management to patients in Medicaid managed care arrangements in the greater Chicago area. And through sort of a decentralized model, care managers were hired by the medical homes to provide services to patients. The patients were required as part of that care management to complete at least one HRA per eligibility spell in Medicaid, though we find in practice that many patients actually had multiple HRAs completed. In fact, for patients who appear in the data at all, we have a mode of about one per year. So if people were showing up more than once, we frequently saw data in subsequent years. Those HRAs were typically collected by the medical home staff over the phone. Actually, if you could just back up for a moment. Oh, one more, I think. So the HRAs were collected over the phone, or if the patient had some sort of adverse health event, typically ED use or hospitalization, they might be collected in person as well. Sorry, I just saw in the chat, HRA is a health risk assessment. So a data collection instrument, sort of a survey or interview instrument for collecting data on medical needs as well as unmet social needs and social risk factors. We had data on about 100,000 unique patients, ages 18 to 64, with up to 5 years of data per patient. And that data spanned from 2015 to 2019. So to give a sense of context, we're talking post-ACA Medicaid expansion, but pre-COVID. And I'll go into a bit more detail about this as well, but the HRA included data on a risk of factors like difficulty paying for medications, lack of social support, and barriers with respect to housing and transport. In terms of the methodology we use to study it, we're looking primarily at just descriptive statistics, so visualizations of how responses to the HRA changed over time. We considered a more sort of statistically intensive regression-based approach, but we found that typically we were producing very similar, if not same answers using additional techniques. So we thought to stick with the visual representation of the results. Next slide, please. So of those 100,000 patients who appeared in our sample, nearly 11% have one HRA in 3 or more consecutive years. And this is the subsample that we focused on. So it's certainly a selected sample. It's only about 1/10 of the data, but we think it's a meaningful subset of the total data. And because we were able to observe at least 3 assessments for this population, we chose to focus our attention there. The patients were further stratified into 4 risk levels after HRA assessment based on a mix of factors, including social risk, utilization, and comorbidities. And those strata were low, medium, and high, and the low strata was further partitioned into those with and without social risks. So you can think of the medium and high risk folks as those with particularly high, if we just back up 2 slides, great. Sorry, next slide. The low risk patients were those without prior utilization or significant comorbidities, and those were further stratified into those with and without unmet social needs based on prior NHN experience, as well as documentation in the literature that patients with unmet social needs were at higher risk for medical expenditures and utilization. Now, to get into a bit more detail about what was collected in the health risk assessment, there were a wide range of factors considered, but because of close relationships between the questions that were asked on in the HRA, we chose to consolidate them down to 5 sort of core dimensions. And those summaries are described in the table at the bottom of this slide. So we focused on social support, which addressed the 3 questions you'll see there, needs with respect to transit, housing, finances, and language barriers. So specifically whether the patient's primary language was something other than English. And again, when we were looking at the presence or absence of an unmet social need, we were looking for a positive screen for any of these items by category. Next slide, please. So what did we find? And I think this first slide presents an interesting picture of the importance of drilling down into changes by subcategory. When we look at the panel on the left, we find a slight but fairly consistent decline in the number of self-reported unmet social needs over time. But again, this is a very slight decline, going from just about an average of 0.95 to 0.85 between the first and the 3rd year of HRA collection. So, consistent and statistically significant, but in terms of qualitative magnitudes, relatively small. We see a very different picture when we look at the panel on the right, which splits out those changes over time by that initial risk classification that I described earlier. So if you start with the blue and purple lines, these are the medium and high risk designees. We find a fairly sharp decline from the 1st to the 2nd year in particular in the number of unmet social needs that these patients were reporting. So starting from an average of about 1.5 unmet social needs, the number had fallen to much closer to 1 by the 2nd year. Among those patients with the sort of low medical and comorbidity risk, but with unmet social needs, we find a relatively flat and stable trend that looks a lot like the overall trend. And in fact, among the lowest risk folks, we do see an increase from the first to the second year in terms of the number of self-reported unmet social needs. And I'll say a bit more about why that might be the case as we get into the discussion of these results. Next slide, please. Oh, sorry, if we just back up one slide there. Great. So the second question that I posed at the outset of this discussion was, what social needs do we actually see changing? And again, it's really important to split out by sort of the observable patient heterogeneity at the outset of our study. So when we split the patients out by initial risk stratum, we see very big differences in results. So looking overall in panel A, that's at the upper left, we see the biggest declines in unmet financial needs and a smaller decline in transit needs. But if we turn to the individual risk groups, so in panel B, where we've combined the medium and high risk patients, we see large declines in those transit and housing needs, or excuse me, transit and financial needs from the first to the second year in particular. And if we look at the lowest risk folks in the bottom right panel, panel D, we actually see increases in each of these categories of social need from the first to the second year. In particular, across these panels, we see a fairly consistent increase in self-reported language needs. And I'll talk a bit more about that in the discussion as well. Next slide. And this is just a quick summary of the findings I walked through. So the largest declines were in financial barriers, a slight increase across the board in self-reported language needs. And again, we see the largest changes in the medium and high risk enrollees. Next slide. So just to give some context and texture to these results, the first thing to note is a key limitation of how the sample was formed, and that's that it's a very selected sample. So patients, as I said in my context slide, were only required to fill out one HRA per eligibility spell. So it may be the case that particularly for the lowest risk group, we're seeing disproportionate attention paid to patients who had either unreported needs emerge over time or who experienced some sort of adverse health or economic shock that led to higher utilization in subsequent years. So while I would acknowledge that limitation and say, we may see some attrition in years 4 and 5 because we only required 3 years of data, and we may be seeing a not perfectly representative sample of some of these patient groups. It's important to consider that these data point to at least a substantial subset of our patient population, so Medicaid managed care enrollees, for whom there were big changes in self-reported social need over time. So I think it's important to contextualize that finding and think about where it might and might not apply across the board. The decline that we see in unmet needs being driven by the medium and high risk subgroups is consistent with the more intensive care management that those groups experienced working successfully, though certainly that's not definitive evidence, certainly not strong enough to make causal claims about the effectiveness of that care management. We found that financial needs and transit needs were most likely to be met. I think that that's consistent with, for example, new enrollees in Medicaid having financial barriers addressed. But I think that points to interesting questions about the self-reported language needs increasing from the first to the second year in particular. And that could be the case that, as patients get more regular access to healthcare systems, they find that communication barriers emerge more acutely as what had previously been the barriers to accessing care, things like transit and finances, were addressed. Though, again, that's merely speculative. We weren't able to directly test that hypothesis, but it is something we considered. And again, I think to bring this back to the sort of policy implications of the question up front, it stresses the importance of delivering a standard assessment on a repeated basis over time, that at least for a large subset of patients, we see significant changes in unmet social needs over time, and that efforts to document those needs, particularly as we think about integration between clinical and community-based organizations, or efforts to address social needs within a clinical setting, it'll be important to document how those needs are changing over time for a patient population. And I just want to pause there and hand things over to Caroline Fichtenberg, who will be our discussant for this work. Caroline?
Hi, thanks so much, Phil. It's really a pleasure to get to comment on this work. First of all, taking the qualitative work, it was just striking how similar these findings were to the findings that we have been to results that we're finding in work that we have been doing in Trenton, New Jersey, where we've also been exploring the reasons why community-based organizations are not taking up a community resource referral platform. In the case of Trenton, it's the NowPow platform, and it's available to them for free. And we've seen exactly the similar things that you all found in your study, which is that ultimately the tool isn't necessarily that helpful to the CBOs because they either already have some kind of care coordination tool that they use, or they get enough clients that they don't need referrals, or they aren't interested in that kind of closed loop with healthcare. And so this really points to a need in this space, which has just, I mean, these referral platforms have just spread like wildfire across the country. I feel like every single health system feels now that they need to have one because everybody else has one. And yet it just feels like, and I saw a comment in the Q&A, you know, that it's kind of standard practice that when you're developing something, you talk to the intended users and figure out how, you know, what's going to be helpful to them, et cetera. And it just feels like healthcare has, for whatever reason, felt like this makes so much sense to them that of course it's going to make sense to, you know, community-based organizations. And unfortunately, healthcare folks don't really, I think, know that well what the world of community-based organizations is like, and what the needs and goals and limitations are. And so I'm hoping that with this kind of research coming out and the work that we and others are doing, and I think just from the challenges that it seems like everybody who's implementing these kind of platforms is finding, there's going to be a different approach going forward. The other thing I did want to comment on is, you know, this recommendation, Carrie, that you identified around providing funding to CBOs for using the platform. This was actually something that in our Trenton project, we specifically asked about because that was our assumption as well. And so we were doing some kind of formative research to try to understand whether or not that would help CBOs use these platforms, if they would get, you know, some kind of financial reimbursement for using it or incentive for using it, just to offset the costs. And what was striking was that everybody that we talked to people at 16 different organizations, and we talked to both frontline staff and leaders or managers, and nearly uniformly, people reacted fairly negatively to the idea of an incentive. And the reason was that these are mission-driven organizations. And the idea that they would get paid to do something that may not be for the benefit of their clients, or that they don't see as being necessarily beneficial to their clients, didn't make sense to them. And we also talked to 9 communities across the country that are organizations that have been implementing these platforms that have various models of doing it, some of which, you know, did provide, for example, you know, just a grant to offset the training costs, et cetera. And folks that we talked to said that generally the money just, this is not what, you know, although I think it can offset the costs, if there isn't some value to the platform for the CBO, that money is not going to be enough, because even if you're reimbursing for some of the costs, it's just, this is not what CBOs want to be doing. The one exception was a situation where the CBOs were getting paid to provide services, and the platform was just what CBOs had to use to get referrals. And in that case, then, you know, the CBOs were using the platform because that's how they were getting the referrals for the services that they were being paid to provide. So I think that's one model that I think is really worth exploring more. So on that, that's kind of my reactions to the really interesting qualitative data. In terms of the quantitative, that's also very interesting. As you mentioned, there's really very little data that's out there on kind of the trends in social risks over time. And so it's great to see this. The patterns were definitely really interesting. I think, the fact that the medium and high risk groups look so similar in terms of social risks, I think is kind of interesting. This idea that there was like a low risk group, but one that had social risks, I think is also really interesting in terms of how the risk categories were made. I think one of the challenges in interpreting that, and I saw this as a comment come in too, is that it's a little hard to know is this regression to the mean? Is this the impact of care management? The fact that you basically like the groups that start out high go lower in some risks, and the group that start out low goes higher. It kind of goes to this idea of, you basically like move in the direction that you can move from where you start. But so I think it'll be interesting. I think if you have the ability to do a little bit more looking at how the trends differ based on the kind of care management received, although then you have, obviously have so many selection problems because people are going to receive more intensive care management if they have more needs, et cetera. And then I think it'd be really interesting to look a little bit more about which components of financial needs change. You had things in there related to food, housing, and medication. Do you see similar trends for all of those? If you have enough data, I think that would be really interesting. And then I think the last thing also would be like, I'd be really interested in hearing, doing some qualitative follow-up with folks and kind of picking people based on the trajectories that you see with the changes in social risks, and understanding kind of what patients or members have experienced and what they attribute the changes to. So I think that could give you some interesting insights into what is driving these changes. I'm going to stop there and turn it over to our facilitator to moderate Q&A with the great questions that are coming in.
Thank you, Dr. Fichtenberg, for your commentary, and of course the NCQA team for presenting on their study. So yeah, we have quite a few questions that have come in. So in the interest of time, I'm just going to run down the list in order of receipt. But before I do that, Carrie, you had a note in the chat that you want to make a clarification on something, and I wanted to make sure that you had an opportunity to do that.
Sure, I actually put it in the chat, but Caroline's point about whether or not CBOs will find it useful to actually get paid to do work in the platform, couldn't agree more. That's not the right incentive for them, but figuring out what that right incentive is, what benefit they will get from the platform, rather than just, like you said, Caroline, well, it makes so much sense to the medical community, why wouldn't you want to do this, right? That is definitely not enough. They do need to see some benefit from it, but it's not going to be a financial benefit the way it is for folks participating in the value-based payment plans, where we know that these resources and CBOs are helping drive down the costs for patient care, but they're not receiving any of that benefit the way the medical homes are.
Awesome. So, all right, so I'll move on to the next question. So Bowen Chung would like to know, and of course, this question, I'll leave this question open to any of the presenters. So what were the potential wins that the CBO said would be important to them to have with a platform described?
Carrie, you're on mute.
Sorry, I've got two different sessions going. Keep unmuting the wrong one. The one that we heard the most often was that they were actually seeing this as a way to connect their patients, the people they have an existing relationship and are already caring for, back to their medical home to get their medical needs met. Excuse me, which was a really interesting like flip of the perspective. You know, they were seeing it as, this is my patient. You're not referring them to me. I've been working with them for years. They came in my door too, but they may not know who their doctor is, where they can go get care with their Medicaid benefits. So being able to understand more about if they did have an existing relationship, how to work with those people, who their care manager was at the medical home, and being able to actually tell them where they can go get care and what they're eligible for was a big win for the community-based organizations we spoke to. I'm not sure, Caroline, if you've had similar experiences or other benefits you've seen.
I think that makes a lot of sense. We didn't hear that explicitly, but it makes sense given, you know, I think it has to be flipped to what's the value for community-based organizations. It can't be thought of in the context of what makes sense for healthcare organizations. So that makes a lot of sense.
And Carolyn, while we have you, we have a question directed to you specifically. Did you, okay, questions are moving around a lot, sorry. Did you ask, or would you consider asking in a way that translates dollars to additional staffing, or another type of translation from dollars to something potentially more concrete?
Yeah, when we were asking folks about that, we were thinking about smaller amounts of money that I think wouldn't enable organizations to actually pay for an entire staff person to do this. We did, in some of our conversations with communities outside of Trenton, we talked to one where they had given like relatively large amounts of money, for example, $30,000 or grants like that, that I think could pay for part of a staff person. And they still saw that people weren't finding the platform, weren't that interested in using the platform. But I do know, we did hear at least one example of an organization in Trenton where they were using a tool that the state had encouraged them to use, and the state was paying for a person to be at the organization, to be the person that would use the tool. So I do think that's one that could potentially be successful, but I think the other challenge with those kinds of things is how long can that last? And ultimately, if you're providing, for this to be sustainable, it has to be a tool that is helpful for the community-based organizations. And I want to comment just really quickly on, I think, James Misak's comment, sorry if I'm mispronouncing your last name, James, around the value proposition for CBOs being greater efficiency in their own work. I think, and somebody else making a comment about this idea of, you have different health systems and different whatever organizations, each with their own tool, going to the same CBOs and saying, oh, log into this tool and this tool and this tool and this tool. That's definitely not an efficiency gain. It's quite the opposite. And even if it's just one tool, we've got to remember CBOs have other systems that they're already using to do case management. They may have systems that they're required to use for their funding, like HMIS for housing organizations. Having another tool that is not connected to their existing ones that they use sometimes is often not an efficiency gain. So one of the things that was really interesting, I remember one example of an organization where they had gotten the organizations to use the tool. This is where they were paying them for the services. And this person's assessment was like, you know what, this is not particularly efficient for these organizations. It's really not that efficient. They're doing it because we're paying them to do the services. But whether for these to catch on, it does have to be either a really good benefit. And I think the efficiency piece really has to be, there has to be some solution around interoperability so that there's not this requirement that everybody has to use a different platform, et cetera. There has to be much more seamlessness for us to become efficient, I think.
Yeah, and Caroline, to build on that, to just share something from the experience of Medical Home Network, one of the big reasons that so many of the medical providers got on board with using their platform was because Medicaid managed care came in and got a large percentage of the people at their medical practices on one health insurance plan. And so, you know, a large percent of their patients had information in this platform. Great, now I'm going to have two things up side by side, right? That just makes sense. Or I'm going to integrate with this one platform and my normal EHR or care management system. Great, I can do that. But when you've got 10 or 15 and it's maybe 3% of your patients or 15% of your patients, it's just not, the efficiency isn't there.
Thank you for the responses. And the next question is giving me some Phil vibes, so I'm gonna direct it his way. So for the quantitative data, were the individuals the same at different assessment points? And what was the turnover for panel members over time per year?
That's a great question. So for those core analytic results, we only chose people from the panel of, so we had a full sample of about 100,000 patients who showed up in the sample of HRAs at least once over this 5-year period. And then from that, we chose the 11,000 or so who showed up in 3 or more consecutive years of data. So for that 11,000, we have a stable patient panel, and particularly a stable patient panel of consecutive years of data. But what we don't have is a stable panel past that 3rd year. So, you know, you could see some turnover, and we do see significant turnover through years 4 and 5. And also, I think that to some of Caroline's points, particularly about whether this is regression to the mean or selection on the low risk folks who experienced an adverse shock, which would look pretty similar in practice. In those cases, you know, the sample selection winds up being potentially a big driver. And I think that to tie it into some of this conversation about demonstrating the value of a platform or the underlying health risk assessments to your community-based partners, I think it all points to the need for, you know, more sort of prospective evaluation of these kinds of tools that, you know, the incentives may crowd out or conflict with some of those altruistic motives that we were all talking about on the side of the community-based organizations. But I think clearly demonstrating a value proposition with prospective evaluation that helps us get around some of these questions about, you know, is it regression to the mean or attrition in the sample or other drivers of turnover, would help make the case clearly of the value of these kinds of tools and the platforms that convey them.
Thank you, Phil, for the response. So for the NCQA team, we have a few more questions. Are you okay answering a few more? All right. So let me organize. Okay, so Brian Dixon says these lessons and barriers are all part of the curriculum that we teach our public health informatics students. And Brian's curious as to the presence and role of informatics professionals in the implementation of the new system and whether they had IT staff or support.
Carrie, you muted the wrong one. Mute.
I think I would figure it out after the 3rd time. The implementation organization did have IT staff, primarily IT staff, as well as some public health people as well. But I love the idea that you're actually teaching the next generation of students this stuff in a curriculum rather than having people learn it on the job and, you know, make these mistakes over and over again. So that's really awesome. And I would personally love to hear a lot more about that.
Fantastic. So the next question is from Karen Shetsina. Apologies if I mispronounced your last name. We are about to embark upon a similar project in Northeast Virginia, or Southwest Virginia, through our strong ACC. In addition to considering CBO perspectives on participation, do you have any other specific suggestions as we get started for addressing concerns around privacy and consent, making sure the right people are at and stay at the table, and support needs for integrating into existing workflows?
Wrong one, Carrie.
I give up. We do include some specific recommendations on in the paper. One that I will just highlight in the interest of time didn't actually come from this project. It came from another Systems for Action grantee, but I will totally pass along his great suggestion. They actually did a memorandum of understanding for when they got the leaders at the table to explain what their role was, how they were going to engage, why this was important. And that allowed them, when there was turnover, which is going to be inevitable at organizations, right? To actually have a really clear thing in hand to pass along to the next person who took on that role. And I thought that was just an extraordinarily great idea. But stay tuned for when we get that paper posted. And we've got some other great recommendations, and happy to talk with you guys. Caroline, do you have anything off the cuff? I know you've got a couple of publications out there too, so we could probably include some of that stuff when we send up a follow-up to the groups on the call today.
Yeah, you know, I think one of the other things that we learned from talking to organizations outside of Trenton that have implemented these platforms is just, it takes a lot, even once you've kind of decided on a solution, et cetera, it takes a lot of engagement, detailed, kind of tailored engagement for each organization to help figure out, you know, how it's going to work for that organization. But that's once you've kind of decided on a solution. I think the really important thing is that you start from kind of somewhat of a blank slate in terms of and really take kind of a collaborative approach of, let's define together what the problem is we're trying to solve, and let's define together what solution we want to implement. I think that is the biggest thing. You need to have that, because that's what leads to the buy-in, and then you can move from there. The other thing I will say is that there also is sometimes, you know, you can have buy-in at the leadership level, and that doesn't mean it translates to the buy-in kind of at the frontline user level. So that's always, I think, important to think about, is really engaging the, you know, the leaders may see the big picture, like how having more coordination is going to be helpful, but the frontline folks are going to tell you what the barriers to making that happen will be.
Yeah, and thank you, Caroline, for that statement. That was something that struck me, that, you know, the leaders were at the table and said, yes, I can see where this vision is headed. And then many of the challenges, especially around consent and HIPAA rules and stuff, those were really down on the ground from people who interact directly with clients every day and are concerned about protecting their clients' needs, right? And so that, I think, is a really important learning. It's not just sort of the vision of the organization, it's everybody involved in the work along the way. And I mean, of course, workflow, it's not the leader that's doing the work, it's the person who's down on the ground. So you know, in some ways, some of the things that we wrote down in this felt a little bit obvious, and it is being intentional at every step of the way, starting from you know, shared goals, shared mission, and then working every step of the way to say, are we carrying that through with the people that are being involved?
Yeah. And I think that point is so important. One of the things Medical Home Network actually did was change their leadership council, you know, that was advising them on this project, to actually include end users. And that really helped with that problem of, you know, the folks at the leadership are like, yes, this is a great idea, we should do it. We're aligned with this idea, but they're not seeing that day-to-day concern of the people who are actually touching the patients.
I wonder, Carrie or others, if you want to highlight the HIPAA rule, the new notice that came out as kind of on the privacy piece, because I think that's a really, great news.
It is great news, and we were actually able to incorporate that in the paper literally the day before we hit like, okay, we're done with this. So that was good too. So what Caroline's talking about is that a lot of the concerns about sharing things are going to be a little bit more clear for people. The guidance is now better. That in fact you should be sharing information for people taking care of patients. Not a lawyer, so I don't want to speak to the exact things, but we did have our lawyer actually vet the language we used, so it is correct in the paper.
And then I wonder if I can jump in about, there's a question in here, I think that's a really important one, about how do patients feel about the idea of addressing social determinants within healthcare. I do want to say there have been quite a number of studies that have actually looked at that. And the synthesis, the bottom line from my reading of them is that patients generally find it pretty acceptable to be asked about this, because they understand the connections between these things and their health. I mean, they see it every day, but it has to be done in a way that is respectful and in the context of a kind of a trusted relationship. People aren't going to be honest if it feels just like a check the box kind of thing, or if it's not done in a way where they feel safe disclosing, or it's not in a context where they feel safe disclosing it. And another thing that's interesting is that it seems that non-face-to-face ways of asking about this information, so if you, versus a face-to-face interviewer, that there seems to be that people are more comfortable disclosing when they're not being asked by somebody, I think, because that removes a little bit of the stigma. And I'll put something in the chat that's a link to the Siren Evidence Library, where you can look through a lot of this research if you're interested and see some of the results yourself.
Thank you for answering that, Caroline. I actually was going to wrap up with that question, so you must have read my mind. So I'm hoping everyone can join me in a virtual round of applause for the NCQA team. This very interesting study highlighting the potential barriers to collaborative actions and the intentionality needed to make sure that they are impactful. So thank you all. We have a few announcements before class is out. So if you're interested in receiving a certificate of completion for today's Research in Progress webinar, there's a survey at the end. Please complete it. We'll also email you one. And of course, we have upcoming webinars, same place, same time. They're bi-weekly Wednesdays at 12 p.m. Our next one will be February 10th, looking at the effectiveness of early childhood development, relationships addressing pediatric health and social needs. So thank you all. We hope that you join us then. And until then, I hope you enjoy the rest of your day. Thank you to the NCQA team.
Thanks. Have a great day, everybody.
Thanks, everyone.
Thanks.